So thank you for joining me on today's talk, which focuses on the role of imaging in diagnosing LVH, hypertrophy, and its phenotypes. Having issues with the mouse? Okay, there. Yeah. So this is a vast topic to cover, but as a cardiac imaging fellow, most of the focus will be on how imaging helps us in discriminating between these different phenotypes. I will start with how we define LVH using different imaging modalities, and I'll cover the different clinical conditions that we need to keep in mind when we encounter LV hypertrophy. And I'll focus on how imaging can help to discriminate between them. I'll end the presentation with a few slides on what the future holds in terms of using novel techniques to improve diagnosis and risk stratification. I'm running with issues. Yeah, it doesn't allow me to, just doesn't move. Okay, now it does. Yeah, okay. Sorry about that. So LVH is defined as increase in volume of cardiac myocytes or increase in LV mass. It's commonly encountered on ECG. However, echocardiography, cardiac MRI, and CT are the main modalities for evaluating LV hypertrophy, with echo being the preferred first-line imaging modality. Just go one slide. Yeah. So the prevalence may vary depending on the population and the modality used or the criteria applied to diagnose LV hypertrophy. But we know from large population studies that the prevalence is around 16 to 19% based on echo diagnosis. And this prevalence can increase in certain populations, for example, among African American or among obese individuals or those with hypertension, kidney disease, or diabetics. So it's commonly encountered in imaging labs, and although we sometimes hear wall thickness being used to define LV hypertrophy, the proper diagnosis is actually based on the evidence of increased LV mass. The increase in LV mass can occur due to wall thickening, or it could be chamber enlargement. I'll discuss this with the coming slides. On echo, however, the LV mass is reported with reference cutoffs indexed to body surface area for each sex. There is a controversy around whether to index it to body surface area or to height. In practice, we mostly use body surface area, although large population studies have defined it using height, indexing it to height. So we use body surface area, although it runs into the risk of miscategorizing the type of remodeling among obese individuals. LV mass can be quantified using this 2D linear method on echo as a measurement you see, either by A mode or on a long axis parasternal views. And however, to calculate the LV mass, this calculations we see assume that the LV is ellipsoid shape, which may not always be the case. So the other modalities that we can use could be cardiac MRI or CT, and MR is considered gold standard both in quantifying chamber size function as well as LV mass. But 3D echo and CT have also been shown to be comparable in assessing LV mass. So the 3D techniques don't make these geometric assumptions and therefore allow us to make an accurate estimation. On CT and MR, we usually report the normal values based on sex and age, which may be more appropriate since the one-size-fits-all approach may not no longer apply. So LVH could be due to either physiologic adaptive response, or it could be secondary to pathologic conditions, loading conditions, with the most common ones being hypertension and aortic stenosis. Other than hypertrophic cardiomyopathy, we may also need to familiarize ourselves with other hypertrophic phenotypes that can present in an adult age and can mimic HCM. We also commonly encounter infiltrative cardiomyopathies, which do not cause true hypertrophy. Instead, they cause LV thickening due to infiltration of and expansion of the extracellular space. So I'll go briefly through this different differentials. I'll start by loading conditions. So under loading conditions, the heart adapts by either one of these mechanisms. Could be the Frank-Starling mechanism to increase the cross-bridge formation with the aim to overcome the load and maximize the cardiac output, or could be recruitment of the neurohormonal mechanisms to increase contractility, and this could be through activation of renin, angiotensin, aldosterone system, or through increased circulating catecholamines. The heart also adapts to sustain increased in blood in pressure or volume load by augmenting the muscle mass to bear the extra load. Thank you. So under pressure or volume loading conditions, the mechanical input is transduced into a biochemical event that modifies gene reprogramming. It includes genes that regulate motor unit composition or energy metabolism or hormonal pathways. There may be activation of trophic peptides, such as angiotensin 2, aldosterone, or catecholamines, resulting in expression of specific growth factors that contribute to the hypertrophy. And all of this finally leads to sarcomeric addition and increase in LV mass. And there may also be change in the extracellular matrix and collagen composition. Although there have been several research done in this field, not a single signaling molecule has been found to serve as a master switch for clinical hypertrophy. So the process is likely to be a result of several signaling pathways. So the increased LV mass is achieved through, as I've said, sarcomeric addition. And the way in which the sarcomeres are added determines the geometric change of the ventricle or the remodeling. And in response to pressure overload, the parallel addition you see here is the parallel addition of the sarcomeres causes an increase in the myocyte width or cause the wall to thicken, resulting in concentric hypertrophy with a greater ratio of wall thickness to chamber size. And by law of Laplace, such increase in wall thickness along with the smaller cavity radius should lower the wall stress and the myocardial oxygen consumption. So this allows the heart to work more efficiently. And in response to volume overload, on the other hand, the myocyte lengthens by sarcomeric addition in series, resulting in an increase in ventricular volume and eccentric hypertrophy. So this way, the heart tries to meet the demand by increasing the stroke volume. So LV hypertrophy is traditionally classified as concentric or eccentric based on the ratio of the LV wall thickness to chamber dimension. It's now more accepted to describe the LV geometry according to the four-tiered LVH classification. We compare the ratio of the LV hypertrophy to the cavity size by either measuring the relative wall thickness or as is done by echo, or we can also look at the ratio of mass to cavity, as we commonly do with CMR. So as you can see, different cutoffs are used among the two modalities. And in pathologic hypertrophy, this is important because there are studies showing that concentric hypertrophy to be more associated with adverse cardiovascular outcome than the rest of the remodeling. I'll talk a bit about the athlete's heart. So the term athlete's heart refers to the electrical and structural adaptive change of the cardiovascular system due to prolonged exercise, with the aim to increase the cardiac reserve. And these changes can include enhancement of the parasympathetic tone and the increase in the ventricular mass. It can be associated with certain ECG changes, LV wall thickening, and cavity size, change in cavity size. The LV remodeling that takes place in the athlete's heart can be either eccentric, concentric, or not undergo remodeling at all. We've been told that the Morgan-Roth hypothesis that says the athletes engaged in endurance sports develop eccentric hypertrophy, whereas those that do resistance training, such as weightlifters, likely to undergo concentric hypertrophy. But several papers in recent years, they've concluded that the development of an endurance trained heart and a strength trained heart should not be considered an absolute concept. It's true that more concentric hypertrophy is seen in resistance athletes, but eccentric LVH is universally observed in among all the sport disciplines. So we've seen some endurance athletes develop concentric and vice versa. So this is not black and white as we've been, told to believe. There are differences in how the ventricles remodel among the sexes and among different races. There is considerable inter-individual variability in the increase of LV mass in response to a certain loading condition. For example, among male and female athletes in the same discipline of training, as for example, here on the bottom, we see dynamic training. You can see a bigger proportion of women have eccentric hypertrophy compared to their male counterparts. And we see more concentric hypertrophy seen in men, in male athletes in the dynamic exercise. So among the general population, as well as among hypertensives, Blacks were found to have higher LV mass compared to whites. And this was also true among different age groups. And among patients with aortic stenosis, for example, women were found to have more diffuse fibrosis and concentric remodeling than men. And men were found to have more focal fibrosis with more dilated or eccentrically remodeled hearts. Why there is a different, why there are different compensatory response of the LV in response to these different physiologic and pathologic loading conditions? Well, there are several hypotheses, but the exact mechanism behind these differences is not exactly known. It's important. It's important to talk about LVH because several large population studies, such as the Framingham study, for example, they have shown that increased LV mass is an independent predictor of cardiovascular events, including myocardial infarction and sudden cardiac death, with a tripling of mortality rate in subjects with and without non-coronary artery disease or hypertension. And this Kaplan-Meier curve that you see is from the MESA study, which is a multi-center population-based study in the US that enrolled over 6,000 participants from an ethnically diverse population without known cardiovascular disease, and half of the participants were women. So this the LV mass was measured with CMR in this study. And it has been shown, increased LV mass was shown to be a strong predictor of coronary artery disease-related death and heart failure, independent of the traditional risk factors, including a coronary calcium score. In another study from MESA, which included over 5,000 participants that underwent MRI and were followed for 4 years, it showed concentric remodeling defined by elevated LV mass to volume ratio rather than elevated ventricular mass alone to be predictive of incident non-heart failure related cardiovascular events, especially stroke and coronary artery disease. So I'll show a case here of a young Black athlete with a pre-syncopal episode. His ECG shows sinus rhythm with LVH and convex ST elevation with T wave inversion in the V1 to 4 leads. Both his echo and MR showed normal systolic function, mild dilation, and LV hypertrophy. So I didn't prepare a poll, but this is just to ask my audience whether you think it's an athlete's heart or could be a possible hypertrophic cardiomyopathy, and if so, if there is any red flag from the information provided. Okay, so correct. Yeah, so that was a red flag here. So this is important to know because sudden cardiac death in athletes with hypertrophic cardiomyopathy is the leading cause of sudden cardiac death among athletes in the US, with males being disproportionately affected than females. And this also holds true among the population with HCM, where sudden cardiac death and adverse events are more seen among males than females. So there is this international, more like a consensus paper or a guide published in the European Heart Journal to help us interpret an ECG of an athlete. And as you can see here, the ST elevation with T-wave inversion in the anterior lead in Black athletes is benign and considered normal. So there are certain criteria on the ECG that should raise a red flag if we see them. Any T-wave inversion in other ethnic groups is a red flag. From the imaging perspective, hypertrophy of 15 millimeters and more is more suggestive of HCM. But some athletes may have a hypertrophy between 13 to 15, which is a gray zone. And in those cases, we need to look at other imaging parameters to help us differentiate the pathologic from the physiologic adaptation. So small cavity size, for example, is a red flag, or an enlarged left atrium, or such as our case, an abnormal LV filling is considered pathologic. And if there is any doubt and there are no definite, diagnosis afterwards, we can also do deconditioning for 6 weeks or more, and we should be able to witness change in the LV thickness also in the ECG. And I also want to point out that among female athletes, a wall thickness of 12 and above is always abnormal. So I'll go on to hypertrophic cardiomyopathy. The prevalence is believed to be 0.2% among adults, or 1 per 500 person in the general population is not believed to be affected. It's primarily a genetic condition, and it occurs in the absence of other loading conditions. The histologic hallmark are myocyte disarray and fibrosis. The diagnosis is made when there is an unexplained LV hypertrophy, typically wall thickness of more than 15, or 13 if the person is a gene carrier or if there is a positive family history. And again, the current diagnosis stresses the fact that there should be absence of loading conditions, infiltrative or storage disease. But regarding the loading conditions, this can be challenging because in recent years, we diagnose more and more patients with HCM at an older age, and most of them may have a coexisting hypertension, which is a loading condition. So this can be challenging. This is to show the SHARE registry, which included over 7,000 patients with hypertrophic cardiomyopathy. It's an international registry. It shows that the mean age of diagnosis throughout the years has significantly increased, with the mean age being around, 50s. in the last few decades. And 18% were found to have hypertension, and those that were diagnosed after the year of 2010, 23% had hypertension, and 30% were beyond the age of 60, with some of them being even more than 70 at diagnosis. So this has changed tremendously throughout the years, and also the proportion of women that were diagnosed with HCM at later age was significantly more than men. And also those that were diagnosed in later years, we see that they're likely to be a sarcomeric mutation negative. Okay, so we see that 30% of all comers with HCM are sarcomeric gene mutation positive, and 60% of 60% of those with a positive family history or gene mutation positive. Sorry, 60% of HCM are either have family history or they are gene positive, or in the pediatric position are gene positive. Among those that have the sarcomeric mutation, majority are in the beta myosin heavy chain, or it could be in the myosin binding protein C that accounts for, these two mutations account for 80% of the cases. But also there are other genetic conditions that have phenocopies that are very similar with HCM that we need to keep in mind, and they account for a small proportion of those patients that are initially diagnosed as HCM. So this is to show the different patterns. We see among the different phenotypes, the sigmoid type and the reverse curvature HCM are the most common, accounting for 40%, followed by the apical and the neutral HCM. Sarcomeric mutation is most commonly seen in the reverse curvature, 80% of them being gene positive. The sigmoid shape pattern is non-specific, and it can be commonly encountered among elderlies with hypertension. Apical HCM, which we sometimes encounter, accounts for 10% of these patients. They don't have it's not associated with the LVOT obstruction that we commonly see in the other, that we see in 1/3 of the cases in the other morphologies, but it can complicate by mid-ventricular obstruction or aneurysm formation and so on. And this is to show that those that have gene positive have worse cardiovascular events or prognosis. So the diagnosis is based mostly by imaging with the following echo characteristics. What MR can add to that is we can characterize the tissue and quantify the scarring. But otherwise, the LVOT obstruction or gradient estimation is preferably done with echo, although we can also on MR appreciate when there's LVOT obstruction, as you can see by this increased jet at the LVOT area. And with SAM and mitral regurgitation, as you can see. We can also appreciate sometimes abnormally inserted papillary muscles and so on. So LG quantification as a prognostic marker has been, as you all know, has been used as a robust marker of risk for sudden cardiac death, with more than 15% of enhancement of LV mass conferring to a twofold risk in patients otherwise considered low risk with other estimations. So there are different guidelines, the ESC and the American, looking at different parameters that can, that are prognostic parameters that can allow us to stratify these patients. The ESC uses the calculator, risk calculator, to show who are at high, low, or intermediate risk within 5 years. From the imaging perspective, on the AAC, they include LV wall thickness or LV atrial size, which is not based on that many studies, or maximum LVOT gradient, whereas the American guidelines focus on either one of these findings. Could be apical aneurysm or LV dysfunction. LGE has fallen out of favor in terms of the strength of recommendation. It's now a 2B. And we know that there are studies showing that the AAC guideline algorithm actually outperforms the AAC in terms of risk stratification. So this is a case of a 56-year-old female presenting with a complete heart block. So we see that there is concentric hypertrophy, desynchronous septum, but there's mild LV dysfunction as well. We didn't see any LGE, but on T1 maps, we did see a low T1 values. Does that mean anything to anyone other than MR readers here? So any one of these, especially Dan and Fabry or amyloid, can present with an AV block. It's quite uncommon with HCM itself, so it could be either one of these. We'll see. Okay, so with MR, one of our strengths is tissue characterization. How that helps is we look at how the protons in different tissues behave under by applying different techniques or sequences. It could be looking at the longitudinal or transverse magnetization recovery time, which we quantify as T1 or T2 times on mapping. Allows us to differentiate between different tissues. Also, late gadolinium enhancement allows us to identify fibrosis. For example, in T1 maps, other than just being this, beautiful, colorful image, what it is every pixel represents the T1, the mean T1 value of the tissue within that voxel. So this provides a lot of information about the tissue we're seeing. So it's increased in fibrosis, edema, or in infiltrative diseases, or it could be low when there is fat infiltration or in iron deposition. In the T2 map we see it elevated or increased in edema. And as you all know, the ECV mapping helps us to quantify the extracellular volume, and it's quite important in identifying infiltrative diseases. Okay. Having issues with the mouse again. Okay. So among the hypertrophic phenotypes, all of these conditions can happen in an adult onset, some of them. So we need to familiarize ourselves with some of them, although they are quite rare. So both Fabry disease and Danon disease are X-linked inheritance, with males being mostly affected than females, but the females can also present late in age. Not all of them have multi-system manifestation, so making the diagnosis can be difficult, and the presentation could be just progressive, LV hypertrophy or dysfunction. We have also the hereditary ATTR amyloid, which is quite rare, but we should also keep in mind in those patients that present with or mimic HCM. So Andersen-Fabry is an X-linked lysosomal storage disease. It's caused by deficiency of the alpha-galactosidase enzyme, leading to absence or decreased inactivity of the enzyme. And that results in the deposition of the glycosphingolipids in the cells of different organs, including the heart, and cardiac involvement is the main cause of death in these patients. So there's a classic presentation during childhood and or adolescence where we have multi-system involvement, making maybe the diagnosis or clues for diagnosis easier. But there's a cardiac variant which may occur later in age with other organ involvement, and those are the ones we should be more careful not to miss. And most of them can be female, heterozygous females. So the LVH progression is could be initially mild, but as the disease progresses, it becomes more prominent. And patients may present with conduction disorder, or cardiac heart failure. The patterns of hypertrophy, although commonly it's concentric, sometimes the patient may not even have LV hypertrophy at early stage. And when they do, it could be concentric, or sometimes it could even be apical HCM-like presentation. So there are different phases for this. There's accumulation phase. In this phase on MR, also it may be difficult to know if they present with normal T1 and there is no hypertrophy. But as this progresses, we start seeing low T1 because of the lipid infiltration of the myocytes. Like I said before, the fat gives us low T1 times. So this could be our first hint as the disease progresses and enters into the inflammatory and the hypertrophic phase. Then that's where we see the LV hypertrophy with or without LGE. And if we do, the LG is commonly in the mid infralateral wall, as you can see in the image. When this further progresses and there's more fibrosis, the T1 may no longer be a useful clue as it pseudo normalizes. At this phase, they have worse outcome and they have quite advanced. So we preferably try to diagnose them earlier. Cardiac amyloid, initially was AL was believed to be predominant, but now recently with the increased awareness, we are diagnosing more and more ATTR patients, especially the wild type, which is predominantly in elderly male. Some of the clues could start with the ECG, but more than just low voltage, what's actually more sensitive and specific in picking up the disease is the low voltage to the thickness ratio. So in addition, there are other clinical and imaging clues that may lead to the diagnosis. So on echo, we typically see the LV hypertrophy could be concentric or it could be asymmetric. We no longer rely on this specular appearance as it may be seen in many cases. They may have diastolic dysfunction, a significant diastolic dysfunction, and on the global longitudinal strain pattern of the base and mid being more affected in the apical appearance can be helpful, but this is not also a very specific sign as it may sometimes be seen in patients with CKD and aortic stenosis. With MR, we can appreciate the involvement of other structures, including the atrium, not only thickening of the atrial walls or the RV walls, but also we can appreciate this diffuse enhancement in these structures. There are certain sequences like LOCK-LOCKR that allows us to see that abnormal gadolinium kinetics. ECV is very important in quantifying the disease burden. So MR adds to that by allowing this tissue characterization. Among those with AL, ECV is considered a good prognostic marker, those with a value of more than 44%. Also T1. So the LG is also associated with high diagnostic accuracy. Among those with ATTR, as the disease progresses, so you can see in the image, the ECV and also the LG, the enhancement becomes more prominent, and the ECV value of more than 58 has also been associated with poor survival. And those that have ATTR, which is mostly the wild type, we sometimes encounter the hereditary types. PYP scintigraphy has contributed a lot because of its high specificity, but we initially need to rule out AL amyloidosis, as you all know, since there may also be a mild uptake with those that have AL amyloid. But typically, after ruling out AL, if we see a grade 2 or 3 uptake on PYP or DPD scan, then that's very specific for ATTR amyloid. There has been more and more advocation to do SPECT, as it allows us to properly make the diagnosis. Looking at what can help us to differentiate between these different phenotypes, we commonly hear, asymmetry as one, clue, but this is to show that this is very variable. Even with HCM, only 50% have asymmetric aortic stenosis, where we may expect them to have symmetric hypertrophy. Some of them don't. ATTR is usually septal hypertrophy sometimes. AL can be concentric with symmetric hypertrophy. So it's not a very robust method to differentiate among these different etiologies. Strain analysis has been used with either speckle tracking with echo or feature tracking with MR. Certain diseases such as amyloid tend to have this pattern of involvement from base to mid towards the apex. This can be very helpful because the presentation earlier could be with normal function, and our only clues could be these such strain patterns. With Fabry, it's been reported to have also a global circumferential strain abnormality, also going from base towards the apex. But these are not specific findings either. So LG imaging pattern of enhancement does help us differentiate, but not always. But sometimes when they present such cases such as mid-myocardial enhancement where most of the hypertrophy is present, or when the insertion points are involved, that's typical of HCM, whereas this mid-wall, infralateral wall involvement is more common with Fabry, and amyloid, as you can see, more diffusely enhancing global subendocardial or transmural, and with Dannon's disease, for example, sparing the septum could be a clue. But this may not always be helpful. This popular internet meme is to show this alarming resemblance shared between chihuahuas and muffins. It's commonly shared in presentation in artificial intelligence world, but I bring this not to highlight the flaws of AI, but to admit as imagers, we may fall into similar problem in trying to discriminate between two highly resembling entities just based on pattern recognition. So this is where we come to quantifying things. And with MR, for example, the T1 values do add into our diagnostics in that when we encounter very high T1, for example, we're more likely to think that it could be infiltrative disease such as amyloid. Several studies have shown this. Or when the T1s are low, for example, like the case I just showed you, it could be a sign of Fabry or iron deposition. So just looking at the function and morphology may not give us enough picture. With the tissue characterization, we get closer to getting the full picture, although not always. So these are cases to show, just based on the first images, we can say, okay, there is hypertrophy, but when we add T1 maps and LGE into that, we can better, we're better at differentiating between these different causes of hypertrophy. The other thing I wanted to talk about is, so this is how we're taught that apical HCM should look like. The typical, ace of spade pattern and, enhancement where the most of the hypertrophy is. But this is to show a case that we had here that had a patient that had prior MR, and the apical HCM was not actually picked up then. There was no LGE, as you can see in these LG images. With an experienced eye, one can say, okay, that the wall does not thin out as it goes towards the apex, and that may be a clue. That's true, but the patient later on had a CT a few years later, and we can better appreciate now that the apex starts to be more hypertrophied than the rest. So this is to point out in early recognition, we may not be as robust. This is another case of an early ATTR amyloid case, where the only clues we can gather from these images could be on the bottom, it's LG images with only the base being involved. Here on the top right, we have T1 maps. One can say that maybe just the base is slightly, higher T1 times. And this is to point out that not all cases, present as their profile picture in textbooks or in presentations. So we, with more awareness and recognition of diseases and more people being sent for imaging, we fall into this dilemma of when to call early disease and when not to. So this is where I want to talk about maybe the future of imaging. One method could be radiomics. So what we do with radiomics is we try to gather quantifiable data from the images. It could be, shape-based parameters, or it could be geometry and spatial complexities, or voxel intensities. These are not things that we can discern with our eyes. We need a special software to do it. But it tries to gather as much information from an image, which can later on we can use for diagnostics or disease prediction. So radiomics has been used for many years in the oncology world in imaging, but it's recently being studied in cardiovascular diseases. This is a recent publication from Jack to show how it adds to or improves significantly the risk prediction for HCM patients, both compared to, added to the AAC model or the AHA model. And the other technique that's under, in the research world is the diffusion tensor imaging. So this is commonly used for brain MRI, but for cardiovascular, it's mostly on research. What it does is it tracks diffusion of the water molecules, which allows to characterize a microstructure as small as 100 micrometer, and it reveals the underlying myocardial helical fiber architecture. And there are studies that have been shown in vivo that there may be abnormal myocardial laminar orientation in patients with HCM, and this may be a possible technique that can be used in the future. So take-home message is to keep in mind, other than the physiologic, adaptive, and hormone causes of loading conditions, also the other inherited cardiomyopathies and infiltrative diseases, and how imaging can add or complement each other in better diagnosing these conditions. And that there may be novel imaging techniques in the future that allows us to detect disease conditions early and allow us to risk stratify them better. So thank you all. There is a rare cardiac condition conference coming up at the end of this month with experts more to discuss about some of these conditions I talked about. So if you have any especially imaging related questions, you're most welcome. And I would like to acknowledge my supervisors, Dr. Patterson and Dr. Chow, and all the staff in the imaging department for teaching me most of what I know. That's it. Thanks.
Thank you so much for that excellent overview. If anyone has questions, you can either raise your hand here or put them in the chat box for our online attendees. While we wait for questions, I have one. So in your last couple examples, you exemplified how in early disease, it may be difficult to determine what disease process is occurring. How much time do you spend looking at the patient history to help you determine, what you think is happening? And should we be requesting, or would it be easier to request more history on the requisitions? I know we encounter this in the echo lab frequently.
Yeah. So we encounter this a lot, and we end up going through the patient's file to understand the patient's condition better, because of the same reasons you mentioned. So history can be quite suggestive, but sometimes patients could just be, presenting with diastolic dysfunction, and there's a bunch of reason for that, and there may not be other systemic involvement that can serve as clues. Even in some of the inherited cardiomyopathies, as I've mentioned, some of the late presenters in female heterozygous patients, for example, with Fabry, they may not have the typical other multisystemic findings. So the history could just be, LVH, diastolic dysfunction, and then we'll have to figure out what the possible reason is. But this is not to understate the importance of, history taking and, gathering other clinical information. Sometimes it might be vague. Yeah.
Thanks, Betty, for that excellent overview. Just to pick up on what Ellie said, yeah, I mean, scar. I mean, we're often asked to assess scar burden in HCM, and one of the important take-home messages is really scar is one piece of information. We have to look at the whole clinical picture when calculating people's risk. So we try really to look at the history as much as we can. Not only in diagnosis, prognosis, like it's really essential. So appreciate people wanting this information, but we can't take it in a vacuum, essentially. I guess one of the things that I'm really excited about in terms of the future, as you talk about, is there's more and more research going on to do MRI and other techniques without giving contrast. What's your take on that in terms of disease diagnosis?
I think I think it's a great option for those patients that cannot take gadolinium or in certain conditions, but I don't know to what extent it can provide all of the multiple parameters that we currently have with the different techniques, including pre and post gadolinium. That I'm not sure if that can be provided with these newer techniques, these oxygen sensitive and.
Yeah, I mean, there's some research going on now. A lot of it is AI fueled, which shows that you can do scar detection without giving contrast. It's still very much in development. It's very much in its early phases, but and then Matthias, Dr. Friedrich, who spoke here not that long ago, is looking at techniques to do even stress exams without giving stress agents. So I don't know. It's very exciting. Like one of the appeals of ultrasound and MRI for me when I was at your stage is that there's no radiation. It's low risk for the patient. So we're looking at ways to make our tests even lower and lower risk, which I think is very appealing, and yet not sacrificing information. So I don't know. I'm excited about the future. I think there's a lot of promise, but it's still not ready for prime time by any means. I agree with you. Like there's still a lot of work that still needs to be done.
There's a question in the chat from Dr. Burwash. What level of physical activity is considered for an athlete is considered the amount that can induce hypertrophy?
That's a great question. I have to say, from some of the readings I've done, I haven't seen any cutoff for that. But maybe that I haven't, read all the materials. But that's a great question. I haven't seen any cutoff being mentioned or any level being mentioned.
Okay, I don't know. I don't think anyone in the audience has an idea, so we'll look that up.
Thanks for the great talk. Speaking as an outsider, I'm an emerge physician normally. I'm just here doing a fellowship rotation. We have the opportunity to identify these conditions in the emergency department, and often I never think to refer on to cardiology if I just see something like hypertrophy on a ECG, or if I focused somebody and I saw that there was thickening or something like that. Is there any cutoff in your mind or anyone else's mind in the room where you would want to see a referral to cardiology if I would identify any of these features? Or would they just follow up with family doctor, maybe referral as an outpatient kind of thing?
Yeah, so if you see like a significant hypertrophy, let's say 15 millimeters and above, it could be any part of the walls, not necessarily the septum, but very significant hypertrophy, maybe, yes. For those that are in, mild hypertrophy range, there could be so many, like I've mentioned, it could be physiologic or it could be hypertension, which is very common. So for those, maybe not. Maybe it's up to the family doctor to look into the entire, patient's, comorbidities and, recognize what could be the cause of that. But if you see significant hypertrophy, I think that would be correct to, yeah.
I was interested to know what is the sensitivity for TTR amyloidosis for MRI versus PYP, specifically, early stage disease, and sort of informing early initiation of treatment, but also not wanting to do 2 tests. Or is there a need to do 2 tests because of differences in sensitivity?
No, that's a great question. So the most recent guidelines were more like consensus statements. Don't include MR as part of the workup. They mostly, if ATTR amyloid is suspected, then to go ahead and do PYP, of course, after ruling out AL. That's because it's highly specific. And once we rule out AL, some studies have shown 100% specificity. So it's become a non-invasive means of diagnosing it without needing biopsy. So it's very sensitive in the high 90s sensitivity also, and very specific. But I do believe as an MR imager that MR does have added value. Also in diagnostics, it does quite well with sensitivity and specificity in the 90s or the high 80s. But it does have added value in quantifying the disease burden with the ECV quantification, and that could be also one of the early signs of amyloid infiltration before we see fibrosis, the scarring. So I do believe that MR has an added value. Although it's not a common practice to follow patients with, quantifying ECV with MR for now, but that may be in the future. I don't know.
I guess just to be more specific about that question, is there any data to say that you can be either PYP negative, but then MRI positive, or vice versa in TTR amyloidosis?
Yes, but very rare. So when it's PYP negative and MR positive, we're likely to think of AL, but there are very rare types of hereditary ATTR that can be false negative on PYP, but they're not. They're very rare. Yeah.
Excellent. That's a good discussion. Thank you so much, Buddy, for your presentation today.
Thank you.
Everyone that attends in person, please sign up on the back attendance sheets to make sure that you get credit for attendance. Otherwise, we'll see everyone next week. Thanks.